What I'm going to do is to talk a bit about the what led to the development of the Cochrane Pregnancy and Childbirth Group, the sort of early history and prehistory, talk a bit about where we are at the moment and where we may be going in the future. Cochrane Pregnancy and Childbirth Group has been very much at the forefront of developing an evidence base for maternity care. Who in the audience have been Cochrane Review authors? A few. Who in the audience have read Cochrane Reviews? Most people. Okay, thanks very much. That's very helpful. So I was going to start with an old photograph, and I'm showing this to you for four reasons. This is the football team of the Department of Obstetrics and Gynecology at Harare Central Hospital, Harare, Zimbabwe, in 1983. And the first reason for showing you this photograph is that I'm speaking in Northern Ireland. And our top footballer was Raymond White, who went on to become an obstetrician gynecologist at the Mater Hospital in Belfast. And I hadn't seen Raymond for many years, but I was very sad to hear about his premature death last year, so I thought this was a good opportunity just to pay tribute to him. This is me next to Raymond, a sort of attacking midfielder, if you're interested. But the second reason for showing the slide is that there were a number of interesting people around in what was quite a small department at that time. The chap here was the obstetrician to the second and current Mrs. Mugabe, Graham Sellers, which I guess is quite a stressful thing to do. Mike Mbizo is a seminologist. He's not a clinician. He's a scientist, but he's currently director of the Human Reproduction Program at WHO. Our regular goalkeeper, not this one, but our regular goalkeeper, Stephen Manjanja, has just completed a really important and very extensive survey of maternal mortality and morbidity in Zimbabwe, despite all the conflict and unrest within the country. And there were others. Caroline Crowther, who's not in the football team, she was probably holding the fort at the time, has gone on to do some incredibly important work in Adelaide, in Australia, in clinical trials, and she's very much involved in the Cochrane Pregnancy and Childbirth Group as well, and I'll come back to her later. So it was really just to say that every now and again within our careers we find ourselves in a situation where there are really talented, committed, energetic people, and these are opportunities that really should be seized and cherished, and all the sort of synergies that occur when you have a group of people like that. Third reason for showing you it is that as just tying in with the theme of this meeting, that as a young obstetrician, it was learned so many different things from this experience. We were incredibly busy. We were overseeing 40,000 deliveries per year in the service, and 20,000 births took place in clinics run by midwives scattered throughout the city of Harare, and 20,000 occurred within the central hospital. And this is where the partogram was developed as a practical tool, because cephalopelvic disproportion is common, and this was a way of getting women who were running into mechanical problems during labour into the hospital. But an important lesson for me was just how much can be achieved by good clinical skills, careful histories, detailed clinical examination, and really reinforced to me that technology exists to complement clinical assessment and not to replace it. And the fourth reason for showing the slide is that this football pitch is where I first got drawn into what eventually became the Cochrane Pregnancy and Childbirth Group. I walked off the pitch one Friday afternoon and met somebody who had been watching the football match, and it turned out this was somebody called Ian Chalmers, who was then director of the National Perinatal Epidemiology Unit in Oxford. And Ian has an incredible ability of pulling people into his big project. And we got talking, and as a result of that, I became very much involved in what became the Cochrane collaboration. So this is Ian Chalmers on the left here. This is at a meeting in Liverpool to celebrate the 10th anniversary of the Cochrane Pregnancy and Childbirth Group. And Ian is with Murray Enkin, who is now retired. He was an obstetrician in Canada, and Mark Hearse, who was an obstetrician who moved to Australia. And what you see in front of them are some of the products that they, in particular, led the development of during the 1980s, which were the forerunners of what became the Cochrane collaboration. And there's the big 2-volume book, which is Effective Care in Pregnancy and Childbirth, published in 1989, which was the first textbook in healthcare that formally used research synthesis as a basis for making recommendations. So looking at the evidence and basing recommendations on that evidence. There was a smaller book there which was published early in the 1980s, which was really quite iconoclastic, and really it's thinking back, it's odd just how threatening this whole project appeared to some people at the time. That there was a vice president of the Royal College of Obstetricians and Gynecologists who described Ian Chalmers as the leader of a sort of obstetric Baader-Meinhof group. And the idea of evidence really was regarded as quite threatening, as were some of the other things that were pioneered at that time. The multidisciplinary working was really quite novel. Obstetricians, midwives, social scientists, qualitative researchers, all working together in this common project. Engagement with consumers was really very innovative at the time as well. And also there was recognition, this is the Oxford Database of Perinatal Trials, there was also recognition back then, really with very crude IT, that it was important that clinicians need up-to-date information, and to be up-to-date there is a need for electronic publication rather than reliance of the very kind of slow paper-based books. So that's really where, so what was achieved in the perinatal field really was the basis of what happened, where the Cochrane collaboration was developed to tackle all aspects of healthcare. And just to remind you what the Cochrane collaboration is all about, it's an international organisation, aims to help people make well-informed decisions about healthcare by preparing, maintaining and promoting the accessibility of systematic reviews, so scientific, formal scientific reviews of the effects of healthcare interventions. And that is mainly but not exclusively reliant on randomised controlled trials as the gold standard method of assessing the effectiveness of clinical interventions. And there are a number of examples of reviews which have had a major impact. One of the most important, I think, is the review on continuous support for women during childbirth. Lead author is Ellen Hodnett, a midwife in Toronto, who's one of our editors. working with Simon Gates, who's our statistician, Justice Hofmeyr, another editor based in South Africa, and Carol Sakala, a consumer representative from the US. And this is the kind of updated version of the review. 15 trials, almost 13,000 women, and shows a statistically significant reduction in the incidence of caesarean section and other interventions with support during labour and childbirth. And this is really important in all sorts of different ways, because there are many parts of the world where women still receive very little support indeed during labour and childbirth. So from 1995, the Cochrane collaboration was formed, and the pregnancy and childbirth group moved to Liverpool Women's Hospital, where I'm based. So there are now 52 different groups scattered around the world that deal with different care, and pregnancy and childbirth is coordinated from Liverpool Women's Hospital. Pregnancy and childbirth group is still the most productive of the 52 groups by some way, with almost now 400 full reviews published. At one stage, naively, I thought if we got to 300, we would probably cover most important topics in our specialty, but that was not correct. And protocols are kind of halfway stage in the production of a review, with the background, the methods, but without the results, the analysis and the conclusions. So we've seen a steady increase in the number of published pregnancy and childbirth reviews. What this chart doesn't show is the workload associated with that, because with such a large portfolio and with the need to keep reviews up to date, in fact, the more reviews you have, the bigger the workload for the editorial team. I was wrong. We have a trials register. We identify either electronically or through other methods all reports of randomized trials in pregnancy and childbirth. And there are over 14,000 of these reports, and just over half of these have been cited in Cochrane reviews. So there are still almost half of the trial reports have not been cited, have not been covered. So that there's still actually quite a lot to be done out there. And the pregnancy and childbirth group involves a huge number of people in very many different countries, 46 countries around the world, almost 1,000 people who have been review authors or co-authors. We have editors in different parts of the world as well. We now have associate editors. This is partly looking to succession planning, and Tina Lavender, who's here somewhere, I'm pleased to say, is one of our associate editors. And we have great involvement from people who are willing to referee, from consumers who make a very important in the peer review process, both at protocol and review stage, and really important at kind of challenging review authors about things like the outcome measures, for example. What actually are really important outcome measures for consumers, which may differ from what we as clinicians might think. And statisticians, the methods change all the time, and it can be quite challenging keeping up with methodological advances, and the statisticians make a really important job. So the kind of core editorial staff are mainly based in Liverpool, but with some based in Adelaide in Australia. The Cochrane Library used to be published 4 times a year. It's now published every month. So again, used to be published 4 times a year. It's now published every month. So again, trying to make sure that information is as up to date as possible. And we have reviews that will be published, I think, on the 9th of September. They haven't been published yet, but we've put in the biggest portfolio of reviews that we ever have this month for publication, and include just some very diverse topics. Cervical pessary for preventing preterm birth. That this is, instead of putting in a suture in the cervix, using a pessary to try and keep it closed. Corticosteroids for HELP syndrome, a variant of preeclampsia where corticosteroids might or might not help. Different regimens for treating asymptomatic bacteriuria, which we know can be associated with a number of bad outcomes, including preterm birth. Different targets for treating women with diabetes, how rigorous should be the control of the blood sugar. Interventions for nausea and vomiting, an enormously common problem, as you know. Hyperthyroidism, peripartum cardiomyopathy, which is a very rare problem but is associated with a high mortality, a high risk of death. Parenteral opioids, enormously important topic. Treatments for breast engorgement during lactation, and the use of Doppler ultrasound during pregnancy. So very diverse topics, but some really important ones. These reviews will appear in the next week or so. Also, as I've mentioned, the importance of updating reviews. This is actually a major challenge. From the outside, people think it's quite an easy process, that somebody writes a review and then looks to see if there are additional trials being published, and then put the trial data in the review and update it. And sometimes that's how it works, but often it's much more difficult than that. Because of the improvement in the statistical methods, actually it can be quite challenging for review authors to bring a review up to date. But again, there's some important topics have been updated. Ellen Hodnett again, alternative versus conventional institutional settings for birth, and this is a very contentious, controversial area, as I'm sure you're aware at the moment. So that there's a spanking new update about to appear in that. Pulse oximetry during labour, magnesium sulfate versus lytic cocktail. Lytic cocktail is a treatment that was used very much in India for treatment of eclampsia, and again we try and make sure that the topics are international and address international issues rather than just local issues. And surgical procedures for evacuating incomplete miscarriage, again an extremely common, important problem. So the logo of the Cochrane collaboration, what it shows is 2 C's for Cochrane collaboration, but it shows in the middle a forest plot, so a meta-analysis, and the meta-analysis is what the evidence of the use of corticosteroids before preterm birth would have looked like had a meta-analysis been performed in 1981. And in fact, it wasn't done until 1989 for the first time, but way back in 1981, these are the different trials, and this is the pooled statistic, which showed a statistically significant reduction in the risk of death in newborn babies after preterm birth. So the information was available about 10 years before it was formally synthesized, and as a result, thousands and thousands of babies died, in fact, unnecessarily. And the corticosteroid story is interesting as an example of translational medicine. There's a lot of talk about translational medicine at the moment, getting results from the lab into the clinic. And it started with Mont Liggins, an obstetrician physiologist in New Zealand, and his colleague Ross Howie, who was a neonatologist. And Montligans was interested in understanding what caused labour, what was the physiology of labour, and the experimental animal that was used in fetal physiology work for all sorts of reasons was the sheep. And he noticed that if he gave the ewe injections of corticosteroids, they did deliver early, but the fetal lambs that were very premature, in fact, breathed at a time when they shouldn't really have been able to do that. So it was that observation that was taken into initial trials, and the review was the Cochrane review was originally produced by Patricia Crowley, working in Dublin, but was updated fairly recently by Stuart Dalziel, who's a neonatologist in New Zealand, and my colleague Devinder Roberts, who's an obstetrician in Liverpool. And again reinforced the findings that corticosteroids are good before preterm birth, and confirmed that neonatal death was reduced, respiratory distress syndrome was reduced, as was intraventricular hemorrhage, but also found that necrotizing enterocolitis was less common after steroid treatment, as was infection. So this was a really important review, but one that had been out of date for quite a time, but which has now been updated again, and with some novel findings. But there's a difference between identifying evidence and getting evidence into practice. And we had a PhD student from Thailand who did some work with us about 5 years ago. And she did a survey of obstetricians in Thailand through the Royal Thai College, and the obstetricians really all said that they would give women corticosteroids if it seemed likely that they would deliver prematurely. But as part of the project, she also looked at what was happening in one province of Thailand. So this is not the people that were surveyed, but a different group of clinicians working in a different part of the country. And what she found was that in practice, really about a quarter of women who had premature labour, in fact, were receiving the benefits of corticosteroids. So it is still this difficult challenge of getting evidence into practice. And the main mechanism for doing that is through guidelines. Now, really there's been very, very little positive happened in the area of preterm birth since the corticosteroid story first emerged. And preterm birth is still the major perinatal challenge that we have, with the risk of death and all sorts of morbidities associated with it. So I just wanted to share with you something which I think is quite exciting, which is really just emerging this year, and that's the question of whether magnesium sulfate is a useful treatment for women who seem likely to deliver preterm. And where this came from was that magnesium sulfate, as you know, we use to treat eclampsia and women with severe preeclampsia, but it's also been used extensively as a tocolytic drug in the United States. And it's a very poor tocolytic drug. It's not good at suppressing preterm labour. But what emerged was from a case control study was that children who, as fetuses, had been exposed to magnesium sulfate before preterm birth were less likely to develop cerebral palsy later in childhood. And there are all sorts of potential biases to that type of observation, but it provoked a number of randomized trials, which have now been summarised in a Cochrane review by Lex Doyle and colleagues from Australia. And what it shows is that the risk of death or cerebral palsy is reduced amongst the babies whose mothers received magnesium sulfate, as is the risk of cerebral palsy as well. And the theory is that the magnesium sulfate has a protective effect on the vulnerable brain of the preterm baby. So this is potentially quite exciting. So the authors were able to do a numbers needed to treat calculation, and found on the basis of these trials that 53 women with preterm labour or likely to deliver preterm would need to be treated to prevent one case of cerebral palsy. And the implications of cerebral palsy are such that that actually seems a very good ratio indeed. So the Australians have earlier this year, on the basis of this Cochrane review, have introduced guidelines recommending that magnesium sulfate be given to women who are thought likely to deliver at less than 28 weeks. So that's one exciting development. Just wanted to mention a few other innovations. The use of individual patient data meta-analysis. So most of our reviews are based on what are called aggregate data, taking the data from published trials, but it's possible to actually get information about all of the in our case, women who have been recruited into trials. It's a much more complex and resource-intensive way of doing a review, but it is possible, and it allows much more sophisticated assessment of subgroups. Screening and diagnostic tests. So this is a departure from just looking at randomized trials, but looking at whether diagnostic tests predict the outcome that they're supposed to do, and I'll show you an example of that. Overview of reviews. The problem with the attraction of overview of reviews is that if you're interested in a particular topic, say the assessment of the fetus during labour, that there are maybe 10 different reviews that you would need to look at, and there isn't a publication that brings all of those data from the 10 reviews together, and I'll mention briefly an example of that. And also the linkage with clinical trials. So individual patient data meta-analysis, this is one of the few that have been published, very few that have been published in our area, which is antiplatelet agents like aspirin for the prevention of preeclampsia. And this has been done by Lisa Askey in Australia, Lilia Dooley, who's one of our editors, David Smart, who's also a neonatologist from Australia, and shows that aspirin does, in high-risk women, does have a modest but statistically significant effect in reducing the risk of preeclampsia. Screening and diagnostic tests. We've been involved in a project looking at the different methods of screening for fetal Down syndrome during pregnancy. And this turned out to be a much more difficult project than we had anticipated at the beginning. Methodology is quite new, which is part of the problem, but there's also a huge number of publications. And it's an area where there are kind of commercial interests as well, and some of the publications are a little bit opaque, and it's a little difficult to understand where the findings in fact come from. But it's something that we're still working on at the moment, and there's now software that allows us to generate this type of chart. This is a receiver operated curve, specificity, sensitivity. So the perfect diagnostic test would be up here. Identifies all of the condition that you want to identify and doesn't have any false positive results. And these results are for a formula including maternal age, nuchal translucency measurement with ultrasound, and some biochemical tests. But this type of chart allows you to compare different methods of screening and work out which is better than others. The overview of reviews I mentioned, and this is another project that we're just starting at the moment, which is looking at methods of pain relief and labour. Again, trying to get an overview of the totality of information about a single topic. And I think this is again going to be quite a challenging project, but I think a very important one. And these are the methods of pain relief that we will be looking at as part of this overview. Also including challenged by Mary Newburn from National Childbirth Trust that immersion in water should be in there, and she's quite right, so that's going to be in there as well. So the link up with trials, finally, this is something I came across on the internet from somebody in Australia. Meta-analysis is a tool to allow people to become professors of medicine or surgery by plagiarising the work of others. Well, this is unfair on a number of different levels. It's not plagiarising at all, because the source of the data is acknowledged. But in fact, it's also unfair because actually there's a very close link between doing a systematic review and doing clinical trials. And in fact, these are some important clinical trials that have occurred in our specialty over the last 10 or 15 years. These trials were driven by people who were also Cochrane reviewers. And nowadays it's impossible to get funding for a clinical trial without being able to demonstrate that the question is important and that the question hasn't been answered already. And funders will need to see a systematic review either done by yourself as applicants or citing a review done by others to show that there is a valid question to be answered. But another part of this relationship between trials and systematic reviews is the importance of trial reports describing the totality of evidence. And Mike Clark, who is director of the UK Cochrane Centre but based mainly in Dublin now, has written a number of papers pointing out that a lot of trial reports in fact focus solely on the results of that particular trial and don't systematically discuss the results of similar studies. And just as an example of this is a study we recently reported. It was a study performed in Malawi, which is a country with which we've got close links. We did some work and showed very high incidence of prematurity in unselected population, rural population, with ultrasound dating. There were specially trained midwives who did the ultrasound scans, and we found an incidence of 20% of preterm birth. In the UK, that figure's about 7%. Very high burdens of all sorts of infection. We did a trial to see if antibiotic prophylaxis would help prevent the very high incidence of prematurity. And it didn't in our trial, but what we also did in the trial was to do a meta-analysis and include data from all similar studies of routine antibiotic prophylaxis. And what it showed is relative risk of 1.00, very tight confidence intervals 0.91 to 1.10, which is pretty strong evidence of no effect, that this is not the way that we should be trying to improve the outcome to prevent preterm birth. Important problem, but we need to be looking at alternative ways of trying to achieve that. So finally, just to mention a couple of strategic issues that I've already mentioned, the need, the kind of conflict between, if you like, the kind of UK agenda and international agenda. Our funding mainly comes from National Institute for Health Research, NIHR, who are obviously keen to see material that will help improve the quality of care within the National Health Service, but it's important at the same time that we're also very aware and sensitive to international issues that may be important. Volunteer versus in-house authorship. We've very much relied on volunteer authors throughout most of the history of the Cochrane collaboration, and we're enormously grateful to the enormous effort that people have put into this work, and we still very much encourage volunteer authorship. However, we have found that some reviews, some really important reviews, have got really badly out of date. And we now have additional funding from NIHR to manage some reviews, high priority reviews, in-house. The prioritisation was performed formally, involving a number of different stakeholders, including consumer organisations, and that was really helpful. So some of the really important reviews we make sure are up to date because we have the ability to manage that in-house. I've mentioned randomised trials versus other types of scientific data. Logistically, it's quite difficult for the editorial team dealing with this huge workload, and there sometimes are difficult decisions about balancing the importance of new reviews versus updating existing but important reviews, and what are important topics and what are less important topics. So finally, just want to acknowledge the fantastic job that my colleagues do. This is our editorial meeting in 2009. Sonia Henderson is the managing editor of the group, and she's based in Liverpool and does a fantastic job. Metin is at WHO, Justice Hoffmar, Caroline Crowther, Jacques Alfirovich is in Liverpool with me. Jill Geit is a consumer person, works with the National Childbirth Trust, has worked with us on some key reviews, but again is taking on a role of coordinating consumer input. Simon Gates, statistician, Frank Kelly works in Liverpool, Lilia Julie is an editor, Ellen Hodnett I mentioned, Jodie Dodd is from Adelaide, another editor. So all of these people do a kind of fantastic job, and so we've achieved a great deal, but only because of the efforts of the editorial team and also the very many review authors around the world who do such a great job. Thanks very much.